Hello, ladies and gentlemen, dear colleagues. Welcome to this new PCR webinar dedicated to DCB, coated balloon. When and how to use, a discussion with the experts. Indeed, it's my pleasure to have today with me, virtually at least, Professor Bruno Scheller, who is a very well-known, worldwide recognized expert from the University of the Saarland, Hamburg in South Germany, and another German colleague, Professor Michael Jonner from the German Heart Institute in Munich. So, with no further delay, we will display which are the objectives of the meeting today, which of course, as it is a little bit our style, will be a little bit provocative, since we want you to be part of the discussion on this, I wouldn't say new technology, but useful technology to approach PCI in a different way. So we want you to share experience with ourselves, experts that have explored the boundaries of balloon-based PCI. What do we intend with that? Probably you will see cases in which DCB would not come immediately to your mind. And we want to discuss you the strategy to learn whether you agree with these indications and these final results. So talking about the planning, the performance of these cases, about the specific angiographic and clinical cases. And then we have the pleasure of having Michael Jonner, who had a very important background on pathology, to learn about the difference in between neo-intimal and neo-atherosclerosis. So we will start with a theoretic presentation of these different issues, and then we will move in the second part of the webinar through case performed by ourselves in real life. So please, Michael.
Thank you very much, Flavio, and it's a distinct pleasure to be part of this important webinar. So let me start with that. We know that despite the huge success that we have seen with drug-eluting stents, we also understand that there is a problem with delayed arterial healing after drug-eluting stent implantation. And this was first reported in seminal autopsy studies where it was shown that drug-eluting stents have a significant delay in endothelialization as compared to bare metal stent counterparts. And it took several years actually until we noticed also from clinical registries, and I'm showing you on the right panel of this slide, huge registries with patients suffering in-stent restenosis and also patients with stent thrombosis. And what you can see here is that first generation drug-eluting stents, which had obviously an excessive load of drug, have higher rates of late thrombotic risk. And that confirms the first autopsy studies. Now, a very important study, this is from our center, 10-year follow-up of a trial that investigated polymer-free versus durable polymer drug-eluting stents. And what is not so important is the difference between the two devices, but rather that you see in both drug-eluting stents a 3.3% event rate per year after the first year, which tells us obviously something must be wrong with these stented coronary segments. Either it's chronic inflammation or new atherosclerosis, and I will talk about this. This is the concept of instant neo-atherosclerosis, which we will see in the next cases also. The concept behind it is that you see new atherosclerotic lesions forming within the nascent neo-intima after stent implantation. And in the mid portion of this slide, you can recognize a pathology sample that shows you a huge necrotic core full of cholesterol clefts within the neo-intima. So that's the difference to the original plaque that lies behind the stent struts. And also this was confirmed clinically. I'm showing you on the right panel a large registry which collected patients suffering from late stent thrombosis. And what you can see in the Kaplan-Meier curves, there's a left shift for drug-eluting stents, which shows you that neo-atherosclerosis occurs earlier in drug-eluting stents as compared to what we see with bare metal stents. So what can drug-coated balloons do to help us in this regard? You know that they possess a matrix coating, which is composed of the active drug, and also an excipient, which has the role to facilitate drug transfer to the vessel wall. And the major goals of this technology are shown here. It's, of course, dilatation of a stenotic vascular segment and the prevention of restenosis. Now, against what we know from drug-eluting stents, this has to be done in a very efficient way by homogeneous and fast delivery of the anti-restenotic drug to the vessel wall. And the benefits are also listed here, which is an absence of long-standing stent struts, which then reduces chronic inflammatory and responses and vessel injury. It may also allow vascular restoration and remodeling, and subsequently enable shorter duration of dual antiplatelet treatment with conventional that we know from conventional DS, and we will discuss this. Something that is very important, and I'm showing you the cell cycle, the two drugs, paclitaxel and sirolimus, which is an analog of rapamycin, are used. They prevent cellular proliferation in different phases of the cell cycle, paclitaxel being cytotoxic, while sirolimus is more cytostatic. And you can see that it's important that this drug sticks to the vessel wall. So drug retention, please remember this one is very important for any kind of drug-coated stent. And this is a seminal study that simply shows you two things, that when you soak artery tissue in a bath with either rapamycin or paclitaxel or a control compound, which is dextran, you can see that the drug persists much longer in the tissue when you use rapamycin or paclitaxel. And that is explained partly by the higher tissue binding capacity of both rapamycin and paclitaxel when compared to a control compound dextran. And finally, we understand from this study that paclitaxel tends to localize in the subintimal space, but also partitions very significantly towards the adventitia, which is the outer part of the vessel circumference. And sirolimus, on the other hand, is slowly diffusing and really spread throughout the entire artery, where it dilutes down to subtherapeutic levels. How does it look like when we use these balloons in daily business? This is an artery after receiving a drug-coated balloon, and you can see that there's significant fibrin deposition, which tells us the activity of the drug. There is loss of smooth muscle cells and also a matrix replacement by proteoglycans seen in this Turkish green stain. And this tells us that these devices are really effective. I am finishing with a landscape of coronary drug-coated balloons, and these are 11 different balloons. Most of them have CE mark. All of them are using paclitaxel as the antiproliferative drug. And you can see in this case also the Medtronic balloon, the Prevail balloon, which will be used in the next case, uses paclitaxel and urea as an excipient at a dose of paclitaxel of 3.5 microgram per square millimeters. There are also a number of sirolimus-coated balloons that have partly received CE marked and are currently investigated, which I'm showing on this slide without going in further detail. So finally, and this is my last slide, it is all about balancing safety and efficacy also for drug-coated stents, with the difference that we need to have a fast and effective drug delivery to prevent restenosis, but also we don't want to overdo this by delivering too much drug, which would create aneurysm and eventually result in downstream embolization, a common concern for drug-coated balloons. With that being said, I'm giving back to Flavio to discuss these slides.
Thank you very much, Michael. This is very helpful information before we move to the real life and to clinical practice. And I have a couple of questions for you, and of course also from Bruno, who had done very important preclinical and clinical studies. One of the questions that normally clinicians ask is whether if there is a prognostic difference in between atherosclerosis, as we know it, especially the type that develops after stenting and vessel injury with percutaneous treatments, and neo-atherosclerosis. Is it more dangerous? Is it more benign? Is it a difference, or is it the same thing?
Yeah, that's a critically important question, which I'm afraid I don't have the complete answer. But what we know is that obviously neo-atherosclerosis is a common phenomenon that occurs also in second-generation drug-eluting stents, to a lower extent, however, but it does occur. What we know also from pathology is that it occurs more rapidly, and this is why we have this huge concern that in all those patients that we treated with drug-eluting stents, it may occur in several years, even let's say 1, 2, or 3 years, while atherosclerosis in most of our patients takes 30, 40 years to develop. And that's the difference that we have seen.
Is neo-atherosclerosis absolutely pertinent to stent implantation, or is something that can happen without a stent in place after balloon PCI or after drug coating balloon PCI? Do you have an answer? That's a difficult question, I understand.
Yeah. I mean, theoretically, you could imagine that you also induce neo-atherosclerosis by a chronic injury of the vessel wall. Now, the big advantage with drug-coated balloons is that we injure the artery to a certain extent, but we also allow the artery to be continuously healing over time. There's a drug effect, so that means if we overdo our job, if we deliver too much drug, there is a risk of neo-atherosclerosis also. And this is what I meant with my last slide. So you need to balance, really have enough drug to prevent restenosis, but don't overdo it so that there is a risk of other diseases.
Okay. Thank you. Very quickly to Bruno. Bruno, is there a difference in terms of efficacy of sirolimus and paclitaxel in treating atherosclerosis and neo-atherosclerosis?
We do not know this at the moment, I would say. The only thing we have a few randomized data comparing paclitaxel and sirolimus as DCB-based approach for specific types of balloons only. And what we see is that both agents seem to work similarly with respect to reduction of neo-intimal formation. This is what is the model instant restenosis. And for instant restenosis, we have seen quite similar biological effects up to 6 months, at least for both agents. If we look at de novo disease, where we know this effect of lumen enlargement with paclitaxel, the first few data we have indicate that there may be a difference in terms of more lumen enlargement overall after paclitaxel than after sirolimus. And it could be that what Michael showed is we see that paclitaxel has higher concentrations in the adventitia that's sirolimus, which is more equally distributed. And this may be the case because we know that one part of this lumen enlargement we see is due to the fact that the whole vessel gets bigger. And with this bigger whole vessel, you have also a bigger lumen. And maybe this effect is more pronounced with paclitaxel than with sirolimus, but this is very early data, and we have to look if we can see this in bigger trials also.
Thank you, Bruno. This is more pertinent, I guess, to the treatment of de novo lesions rather than instant restenosis, because you are talking about enlargement of the vessel, something that cannot happen once you have put a metallic stent. Thank you very much for the insights. And now I'll move to the second part of our slides in theory, which relates to a very important concept that we have to consider each time we assess a failure of a previously implanted stent. This is a nice paper from the group of Ron Waxman in Washington that made a very important difference about the reasons why a stent may fail. A stent may fail in terms of reocclusion because of mechanical causes or biological causes. So as you can see in the slide, I would concentrate only on the first part, on the upper part. Mechanical issues are related to a bad technique of implantation, that's it, not a good vessel preparation, or the undersizing of the stent. So the underexpanded, the too small stent for a vessel, it's a stimulus for the growth of neo-intima after the damage that we create into the media. And the second one, which is much less frequent, is the stent fracture. It's something that has to do with the old models of stents, or in cases of very complex interventions in bends and calcification. The other reason is the biological response, which is different in any patient, has some predictors that we will soon see, but it's mainly due to the neo-intimal hyperplasia. So it's the excessive growth, it's the excessive healing of the tissue after the damage that we create with the stent. This is the most common. Then, of course, we have heard, Michael, about the difference in between neo-atherosclerosis and good old atherosclerosis, and this make could make a difference in terms of clinics and treatment. So which are the predictors of restenosis? This is a little bit an old slide, but it's tell us one of the most important concepts we want to share with you today. And this is the main predictor of stent failure, which is stent length. The longer the stent, the higher the risk of having either restenosis or thrombosis, the two ways a stent may fail. So this is the most important predictor of failure. It doesn't matter which type of stent, bare metal, drug-eluting, with the release of any kind of drugs. And the other one is the damage that we create to the media of the vessel wall. But as I said, these are quite old data. This is an example of what is a stent fracture, what, as I said, is not so frequent, but it's a clear cause of stent failure at the long term. And then I would like to share with you what the European guidelines recommend to analyze this cause of stent failure, which is the assessment of the stent failure by intravascular imaging. As you can see in these slides, these are examples of edge dissections that may not be detected by angiography and may be a cause of acute recurrence of ischemia after stenting. Neo-intimal hyperplasia, as I said, the most common mechanism that evolves in the first 6 months after stenting. Neo-atherosclerosis, something that would happen late on time, or simply the malapposition of the stent when the stent is too small, or the late acquired malapposition, something that was very common with the first generation drug-eluting stents, less common today. So based on this classification, in-stent restenosis is still a clinical issue. It happens in about 10% of PCI despite the new drug-eluting stents. It's a multifactorial effect, as I said, related to the procedure, the device, and the biological response of the patient. And of course, the identification of the mechanism absolutely requires additional imaging. This cannot be done just by angiography. Indeed, the European guidelines recommend to use drug-coating balloons or drug-eluting stents to treat stent failure with the same level of evidence and the same level of class of recommendation. And as you can see, immediately after, to interrogate the causes of this failure, it is advised with a 2A level of class of recommendation to use intravascular imaging, either ultrasounds or OCT. Then it's important that we avoid adding metal layers because the lumen of the vessel will get smaller and smaller. And the last concept is that the most effective device we have today to enlarge the lumen of an under-expanded stent is, with no doubt, intravascular lithotripsy, although this is still an off-label indication. These are some very quick examples of how it looks. The homogeneous and bright uniform layer of neo-intimal hyperplasia in IVUS, much more clearer to see in OCT. Okay, this is a clear example of under-expanded stent far away from the media of the vessel, and this is a cause of mechanical failure, which can be also seen here in OCT. But now I will show you an example from my practice where you see a patient that received a stent in the proximal LAD and in this small circ. This patient had restenosis of a bare metal stent, was treated with an everolimus eluting stent and had restenosis. His long history stopped when we did finally the DCB treatment with drug-coating balloons. So follow me on the IVUS, which is the mid LAD, with a nice vessel diameter. And at a certain point, you will see that there is calcium and stents. You see here there is some neo-intimal. This is one stent. And you will see the two layers of stents. The first one, the external, it's a bare metal, and inside it's an everolimus eluting. But the clean area after the DCB treatment, despite the underexpansion, which is clearly underexpanded. So this shows the effectiveness of DCB. Same thing in the circumflex, where you can see that the vessel, it's very small, and there are two overlaid stents. The outer is a bare metal, the inner is an everolimus eluting, but the inner lumen is totally clean after the release of paclitaxel at 9 years follow-up. So this is to show you how effective it can be, the treatment with DCB after failure, without adding a third layer of metal that would, of course, practically occlude the vessel. So this was my part based on imaging, and now we will move to the third theoretical part of our webinar. I will hand to you, Bruno, to talk about the indications we have on the management of the antithrombotic therapy after DCB treatment.
Yeah, thank you, Flavio. So the question is, how long do we have to use dual antiplatelet therapy after DCB treatment? Because it's different from the concept to a tracheostomic stent where we implant a new implant. Interestingly, the 2017 ESC focused update on dual antiplatelet therapy does not distinguish between the different devices. They have a common recommendation for tracheostomic stents, bare metal stents, or DCB. And Michael has shown earlier in his studies that there's a difference in endothelialization, for example, between a bare metal stent and a tracheostomic stent time-wise. And therefore, it is a little bit astonishing for me that these guidelines do not differentiate between different devices. So the recommendation is for stable coronary artery disease and patients without high bleeding risk, 6 months of dual antiplatelet therapy. And if there is high bleeding risk, 1 to 3 months of dual antiplatelet therapy. If you look at acute coronary syndrome, it's clear for all devices, we have 12 months recommendation without high bleeding risk and 6 months recommendation with high bleeding risk. And with respect to patients undergoing oral anticoagulation, there's also the same recommendation independent from the device implanted. What is the rationale? Basically, the rationale for using dual antiplatelet therapy during PCI. We want to reduce acute thrombosis during our angioplasty. We hope to reduce periprocedural damage with respect to distal embolization, for example. And that's the most important thing, we want to avoid any device-related thrombosis. And for the stent, we know that we need dual antiplatelet therapy to reduce the risk of acute and subacute closure. The question is, if we do not implant a stent, do we have to prevent stent thrombosis? Because there is no stent. Unfortunately, we have very limited data to these questions, and I will show you what we have for the use of DCB. Before I show you this limited data, once again, why makes it a difference? If you look at the track distribution to the vessel wall, below you see with the green color marked the track distribution with DCB, which is very homogeneous. And if you look at the stent struts, then you see that the highest concentration of the drug is in the area where the stent struts are, where you need the endothelialization. Therefore, it makes a big difference, in my opinion, if you use a DCB or stent with respect to your thrombotic risk. This is a meta-analysis summary of all the different dual antiplatelet therapies in DCB trials. Here is for the ISR, and as you can see, DAPT times in different trials were between 1 month, for example, in the Packard ISR 1 trial, we did that first men trial, and up to 12 months. The same applies for de novo disease, small vessels. Here we are in the range between 1 and 6 months in the different trials. And if we look at those trials, also including large vessels, it's again a huge a huge variation, again, between 1 and 12 months dual antiplatelet therapy. So we have no clear regimen in the trial so far for DCB. If we look a little bit more in detail on the trials, we know how long dual antiplatelet therapy was applied. Then we have, for example, the PEPCAT-2 ISR trial. This was a trial where we treated bare metal stent restenosis either with DCB or with drug-eluting stent. And here you can see very clearly that in the DCB arm, the 4 weeks DAPT time was done in about 70% of the cases. 30% of the patients had longer DAPT times. And in the drug-eluting stents, the majority had a longer dual antiplatelet therapy. We have some registry data, for example, from Thomas Risan's group from Finland, 487 procedures, half of it stable CAD, half of it acute coronary syndromes. And they applied a short dual antiplatelet therapy in the stable population with a median of 1 month and a mean of 2.8 months. And in the ACS population, it was also relatively short, median 1 and mean 3.3 months. And interestingly, they report that about 4% of the patients did not receive any ADP receptor blocker at all during or after PCI. So we have a very limited number of documented patients having short or no DAPT after the treatment with drug-coated balloons. Here we have another series, 303 patients from the UK, from Simon's group. They applied a strict 1 month duration of DAPT in elective patients, not ACS patients, and they report a very low MACE rate in those patients treated with only 1 month of DAPT. We looked at high bleeding risk also in the basket small 2 trial and at the DAPT times, and we did not found real differences. There was a trend towards a lower bleeding rate of severe bleedings in the DCB arm. However, if you look at the application of the DAPT, it was very similar between the DES and the DCB arm. And this has to do with the fact that we treated small vessels in the trial, but most of the patients had other interventions at other vessels during the study period. And therefore, there is no clear differentiation in this study population between DCB and DES randomization with respect to dual antiplatelet therapy. For patients with high bleeding risk, we have the DEBIT study, again from Thomas Risan from Finland, and he randomized DCB only against bare metal stents, both with 1 month of dual antiplatelet therapy. The event rate was very low in the DCB arm. However, the limitation of this trial, of course, is that we have no comparison with drug-eluting or drug-coated stents with an DAPT of a time approved for 1 month. So he further reported at TCT a few weeks ago additional registered data, 232 patients with single antiplatelet therapy after DCB treatment in high bleeding risk. And the results were very good, but it's not randomized data. He started now a randomized trial with about 700 patients randomized, drug-eluting or drug-coated stents with 1 month of DAPT versus DCB only with single antithrombotic therapy. And the primary endpoint is a combination of MACE and bleeding events. So maybe this trial will give us more information in the future about the feasibility of reduced antiplatelet therapy after DCB treatment in high-risk patients. Currently, and this is again only expert opinion, the international consensus group recommends the international consensus group recommends a DAPT of 4 weeks after DCB only in de novo vessels. on the basis of expert opinion, and they hint to the fact that there's limited data for single antiplatelet therapy in patients at very high risk.
Thank you, Bruno. Thank you very much. There are so many questions coming from our colleagues, which is a very good sign because they are interested. I will try to go very quickly in the next 5 minutes before we move to the cases to satisfy their request. First of all, is there a higher risk of acute or subacute thrombosis with DCB compared to stents? Is it higher or lower or the same?
It depends what you're doing. If you follow the rules of DCB only, this means you have to prep the lesion and then decide if you have an acceptable result, if there's a flow limiting dissection, yes or no, and if you have a sufficient initial lumen gain, and apply dual antiplatelet therapy at least for the procedure and maybe the first few days, then the risk is not higher than with drug-eluting stents. There are some data indicating it's lower because we have no implant and no stent thrombosis. If you do not follow these rules, then you may be at risk also for vessel closure after DCB.
Okay. Michael, is primary PCI a good indication for you to use DCB?
That's a tough question. Well, I personally believe, first of all, in primary PCI, our first goal is to restore flow, right? So I think if you have, it depends really on the plug. I mean, you can also have a STEMI in the setting of a chronically diseased LAD, let's say, but you can also have the type A lesion that ruptured. And I think in this case, it could be used indeed. And there have been pilot studies just doing PTCA, either using plain balloons or drug-coated balloons. So that would be my answer. It depends on the lesion a bit.
So while I asked our technicians to prepare the first case, which is a very nice case made by Michael on recurrent stenosis, I addressed to Bruno the next one, which is a very smart question. Bruno, a colleague, Javier Moreno, asked whether it would be better to pre-treat with cutting balloons to enhance to facilitate the transfer of packed media compared to normal regular balloons.
That's a very good question. We do not have a clear answer on it. What we know is that with higher dissection rate, we may have better drug entry to the vessel wall. That's what we know. And what we can create with cutting or scoring balloons are controlled dissections at the end of the day. So this supports the use of it. I like to use scoring balloons for lesion preparation because they also create dissections, but they are different from what we see with conventional balloon catheters for pre-dilatation. So that's the answer. No clear answer, but I think it's not a bad option to use specialty balloons.
Makes sense. Yeah. Shall we go to the first case, please? So because I'm sure that our colleagues will love them. And Michael, please guide us on this complex story of your patient.
Yes. All right. Thank you. This is an interesting case. I'll start right away, of a 65-year-old female who was admitted to our chest pain unit with unstable angina. She suffered from a coronary artery disease and had really multiple PCI to the RCA between 1998 and 2006. And I think some of you or all of you will know these cases. They are rare, but they do occur, where you have recurrent instant restenosis. Patient was finally, because of frustration, underwent CABG with REMA grafted to the RCA in 2006 and has some comorbidities that are listed here. This is the ECG, which is not very remarkable, and some slight elevation of CK without troponin at this point of time. Quickly to go through her past PCI history, you can see 4 times PTCA between October 1998 and September 2002. it always in the proximal RCA, then received finally a cipher stent in 2003 in the proximal RCA. She came back for instant restenosis in 2006 and received a 40 millimeters taxus stent in the proximal RCA. Unfortunately, she was coming back even in 2006, and by that time, rotablation was attempted without being successful. Obviously, some of the operators had the impression of calcification, and finally they ended up implanting another cipher stent, 3.5 millimeters in diameter, and the patient kept coming back, unfortunately. In August 2006, because of no further options by that time, it was decided to graft a RIMA to the RCA. And finally, the patient was coming back several years later in August 2020. And this is the angiogram that we ran by that time. And you can see again severe instant restenosis in the proximal portion of the RCA and also the ostial RCA. And there, also, unfortunately, the bypass graft, the RIMA graft, was occluded. So we asked ourselves what to do next. And it was decided, of course, to proceed with PCI. By that time, she was already operated on. And we first decided to gain a bit of lumen by using an OPN balloon at very high pressure but low diameters, 2.5, in order to be able to perform imaging. Because as Flavio has nicely illustrated, I think it's critically important these days, as we have these tools, to perform imaging, to understand what's going on. And the summary of this pullback, which runs while I'm talking to you on the right side of the slide, is that we see significant stent under expansion that was treated by several stents. Actually, was never fully expanded, as shown in this nightlight. And this was combined with severe in-stent neo-atherosclerosis and calcification within the neo-intimal. So the question is really what to do here. It's really a difficult one because you can use balloons, but as already also illustrated by Flavio, we decided, because of the combination of stent under expansion and calcification, we decided to go with intravascular lithotripsy. This is a 3.0 by 12 millimeters balloon, 80 pulses each, twice delivered. And this is the result after doing lithotripsy. And I think we see a gain in lumen, but still significant restenosis. Therefore, it was decided to go again in with high pressure inflation, non-compliant balloons, OPN balloons, 3.0, 3.5, up to 35 atmospheres, and then also a scoring balloon, which we always like to use in order to modify the neo-intima, which prepares it for the last step, which is a drug-coated balloon that was used here, 4.0 Prevail balloon by 25 millimeters, 30 seconds at 12 atmospheres. And this is the result, which I personally believe by that time was a very excellent result, given the fact that this patient in this location had several instant restenosis and a lot of neo-intimal tissue. So we decided to leave as is. And fortunately, we have an angiographic follow-up at 6 months, which I'm quickly showing you. There's not a lot to talk about with regards to the left coronary system. More important, of course, the RCA, and you can see it looks perfectly fine. As a matter of fact, my impression was that there was an additional gain in lumen, and that is what Bruno, I think, was referring to also, even in the fact that you have stents in there. It may also just be our thought, but this is what my impression was like, and you can see here a perfect result. So at the end, a patient with several instances of instant restenosis finally was treated by a drug-coated balloon, and it turned out to be fine at 6 months. We hope to see the patient back after 1 year. Thank you very much.
Fantastic case with a clear demonstration of how effective this therapy could be in a patient that has tried everything, I mean, until a mammary graft. There are very appropriate questions on this case, so I will address them immediately. Todd Stephens is asking, this goes to you, Bruno, whether a drug-eluting stent, which is releasing limus and creates restenosis, would be treated with a drug-coating balloon that release limus, or with a different drug, with paclitaxel, and in this case, if the difference may have some unexpected effect.
Good question. I remember there was a trial, I think ESA Desire 2 from your group in Munich, where tested the hypothesis that changing the drug. This means Cipher or Taxoset at this time makes a difference, and I think there was no difference between the two drugs in terms of efficacy of treatment of ISR. For the DCB, we have these two small mechanistic trials from Malaysia and Germany we recently published, where again we see no difference between paclitaxel and sirolimus-coated balloons in terms of reduction of neo-intimal proliferation after stent failure. So at the end of the day, in my opinion, it makes no difference. You should use this DCB you have in hands and where you have good clinical evidence. That's my recommendation.
Thank you. Very short question to you, Michael. A colleague, Ahmad Saran, is asking whether an underexpanded stent that has been implanted after a stenosis, therefore remaining underexpanded after DCB, can be a reason of future restenosis.
For sure. I think this is a clear yes. Underexpansion, we know from all major IVUS studies and imaging studies, is the critical component of instant restenosis. I think in the past we have underestimated really stent underexpansion. So this is critical. This is also why we decided to really take time to predilate, to try to increase the lumen of this artery and provide better stent expansion. Although we know after several stent layers, we remember these were one cipher, one taxis, another cipher stent. It is difficult to really achieve good stent expansion, but we tried our best using also lithotripsy in this case. Yeah.
Okay, thank you very much. Shall we go please to the next case? And while we prepare, we confirm again that once you have underexpanded stent twice, what you shouldn't do is to add a third one. For sure, try to open the vessel as much as possible. So I go with this elderly male in chronic atrial fibrillation, diabetic, treated with anticoagulants, who came to our observation nearly 1 year ago because of chest pain, typical, with mild anemia, but he came also for active bleeding from the urinary tract. Because of the non-STEMI presentation, mild ischemic ST changes in the anterior wall and typical chest pain and mild troponin rise, he underwent coronary angiogram just for a diagnostic purpose. When we saw that it was actually not very high risk, we left him and he went to the operating room because he needed an emergent partial resection of the tumoral mass that was actively bleeding. And he was kept in the intensive care unit for 2 days after transfusion. And he came to the cath lab to perform the angioplasty that I will show you immediately on aspirin and heparin, and was loaded with Plavix the same day of the PCI. You can see that the ECG is not good quality, but there are no big issues, just some mild signs of ischemia. At the same time, he was a little bit anemic, so we were not so worried. The right coronary artery is dominant, is very large, and as you can see, hope you can see it, it's very, very, very calcified. And you can also see that the LAD is calcified. This is the left coronary system, where you see this bifurcation of the first diagonal and the LAD having nearly the same importance. It's a bifurcation of two vessels that will perfuse the anterior wall in a similar way. Again, the patient has preserved LV function, so this is a good sign. And so we prepare for a PCI, which on the intention, because of the length of the stenosis, the calcified and the small vessel of this lesion, was intended to be a balloon only, without stents. So it's first a lesion preparation. You can see that despite going high with the atmospheres, with the non-compliant 2.5 non-compliant balloon into the LAD, there is still balloon under expansion. The diagonal with the same balloon performs better. It expands better. So after the lesion preparation, you see a 2.5 drug-coated balloon on the diagonal. Further preparation with the cutting balloon 2.5, 10 millimeters in the LAD, and then the DCB 275/20. Then there is a final kissing, keeping the DCB on the LAD and just adjusting the carina with the 2.5 semi-compliant balloon in the diagonal. And this is the final result. The vessels are open, the flow is good. Of course, this is not a stent-like result. There is clear dissection of the diagonal and the LAD with no chest pain, no ACG changes. This is the QFR analysis that was performed afterwards. This is the baseline which confirms the significant stenosis with the 0.79 QFR on the distal LAD. And this is the result after the PCI with a better result, not stent-like, it's 0.91. We have nearly 1 year follow-up of this patient. He had no in-hospital complications. He was discharged on NOAC with clopidogrel and aspirin for only 7 days. Then aspirin was stopped on day 7 and Plavix on day 28. On day 30, he underwent the radiotherapy that was planned. And so far, after nearly 1 year, the patient is doing well. And his 1 year follow-up elective is scheduled soon. We hope we will be able to show you the result at 1 year of this gentleman in the second part of this webinar. So, any questions?
I mean, I might have a question, Flavio, because this is a very thought-provoking and intriguing case. How is there anything special in how you monitor your patients if you see, you know, a certain level of dissection? Is it any different from the patients that receive stents?
Well, this is based mainly on your own experience. This is one of the most difficult points, and of course, is where we have to work hard in showing cases, discussing our experience, good and bad results, because of course, this is what worries more the operators. When you see a dissection like this with normal flow, with a residual stenosis which is mild, is 20 to 30%, the patient is doing good, you can wait for 5 minutes, there is no ACG changes and the flow is good, I really leave these dissections because putting a 2.5 long stent will be much more risky to have stent thrombosis than the eventuality of having acute or subacute occlusion because of these flaps. So unless you have really a low flow and chest pain, I am very forgiving with the dissections. Otherwise, you will be implanting many stents where you don't want to implant them because of the length and the diameter of these small vessels.
Yeah. And maybe a question to Bruno. How important do you think is antiplatelet treatment or anticoagulation in these cases? Because we have not done with plain old balloon angioplasty. So is there any difference these days that we treat these patients with more effective DAPT?
I think so. I think my feeling is, without having any data on this, but I think that if we treat de novo disease with DCB and having dissection, which is the case, dual antiplatelet therapy, at least within the first week, is very important to be on the safe side. The problem is we do not have the data to show us these things. But if you remember that this implant, this fresh implant stent, gained so much from the dual antiplatelet therapy, then we can at least assume that the dissection, which can also create thrombosis, may also benefit from dual antiplatelet therapy in the early phase.
Yeah. Well, I cannot tell you how many questions are coming. Of course, we will not be able to address, but everyone is concerned about how to manage the dissections after the use of balloon. And one technical point where the use of a non-compliant balloon after DCB might impair the efficacy of the drug that we have delivered. I would say to this colleague that you should choose the drug, the non-compliant balloon before, because lesion preparation is very important. The DCB is the last device that you will use. Do you agree with that, friends?
Fully agreed, yeah.
Absolutely.
Okay. So we would like to keep on discussing, but we have another case. Maybe the time is short, but I will ask you to show it, because even if we don't discuss it in depth, it will be nice to have this case at the follow-up hopefully by the time of our next webinar. Can we show the third case, please? Thank you. This is a young patient. This is a young patient who had chest pain under effort for 6 months. He didn't come to the hospital until he had chest pain at rest. And when he came, we wait the day after, he underwent the coronary angiogram, and this is what we thought could be the culprit lesion. It's a total occlusion of the LAD. We might discuss whether this is chronic or acute. I think that this is acute because, of course, he had no chest pain at rest before, so we consider this as a culprit. And occasionally, we found this non-culprit lesion, which is located in this rather big first oblique marginal. So what to do? I mean, I think that very instinctively, we would try to stent the totally occluded LAD and perhaps consider the drug coating balloon strategy on the SERT because of the apparently simple angiography of this vessel. As you can see, using a normal pilot 50, the wired cross with a little bit of work and attention. So probably I am confident to say that this was not a total occlusion. And after the wire crossed with a 2.0 semi-compliant balloon, we achieved flow. So then, as I said, lesion preparation is key. This is a semi-compliant 2.5 long balloon, and lesion preparation in the distal vessel that you can see is diffusely diseased with this 2.0 30 millimeters. And this is the aspect of the vessel after balloon only. Then now it's coming the provocative part of this case. I decided to go with Prevail, paclitaxel eluting balloon, 2.530 in the mid part and 2.530 in the distal part of the vessel. And this is it. So I'd like to know your opinion very quickly, Bruno and Michael, if you think this is acceptable or we must put a stent on the mid LAD. Michael,
I personally believe it looks fantastic. I think the stent couldn't do any better at this point of time. So I agree with you. Very good result.
Bruno.
Yeah, absolutely. That's what I'm also doing in these cases. However, you can say, okay, our primary lumen gain in the mid part of the LAD is worse than we would have it with a stent. That's for sure. If you use a 3.0 long stent, then it looks better cosmetically. But the good news is that I assume that if you look at these patients several months later, the mid LAD will look much better, will look bigger than it is the case now at the end of your procedure. And that's the beauty of the therapy. You do not have to reach the stent-like result. You can trust that an acceptable result will end up in the stent-like result over time.
Good. Can we go back to the case? Because now we have to deal, we are not obliged to do it, but we have this non-culprit lesion, which looks like a type A, all classification type A, quite simple lesion. So on my mind, having been so lucky with the treatment of the totally occluded LAD, I decided to keep on treating this patient without stents. And this is a semi-compliant 3.0 12 millimeter short balloon. But as you can see on the right panel, after dilatation, there is still an important 50% residual stenosis. So I got more aggressive and I used a non-compliant 3.0 12 balloon. You will see it is inflated, and it seems that the release disappears, but when you deflate the balloon, there is a kind of recoil. So at that point, Bruno, what would you do? Would you insist with the DCB, or you think this is not a good lesion for DCB?
This does not yet reach the quality criteria of an acceptable result. So my next step would be to use a specialty balloon, scoring or cutting balloon, and look if I can improve the result of this pre-dilatation.
You would insist further. Okay, let's see what I did. Probably I was not feeling like being so patient with this. So for me, next was a stent. This is a 3.522. I wanted to cover all the bands because I had the doubt that probably the balloons were moving a little bit. I wanted to cut. There was some foreshortening. But even after a 3.5 stent at nominal pressure, you see that there is still a residual stenosis, which is not acceptable. Ideally, I should have done IBUS, but you don't need IBUS to understand that this stent is underexpanded, and it got definitely better after a 3.5 non-compliant balloon at high pressure. So this is an example of how things might be unexpected. In this non-chronic but total occlusion of the LAT, we managed fairly well with only balloon-based technology. And in this type A lesion, which should be a simple one, I wanted to do it with DCB, but in the end, I decided to implant a stent. So that's to show that we don't need to be, I'd say, exaggerated and trying to, stents are there for being used, and if you have a residual stenosis and your lesion preparation is not adequate, there is nothing wrong using stent in this 56 years old male with diffuse disease. I hope we will have the follow-up and be able to share this case with our colleagues at the next webinar. So we have 4 minutes left. I think there is another question I'd like to address. We make this point clear. This is a Medtronic-sponsored webinar with an unrestricted grant, so we can say whatever we want. And why I say that? Because drug-eluting stents are not, let's say, supported by evidence to be used in bifurcations. But in clinical practice, we find it as a very good idea, and personally, I do it, and I know that all the experts do. And this is pertinent to the question that one of our colleagues have sent, saying, if you treat a bifurcation, Bruno, would you apply the drug-coating balloon in the side branch before putting the stent in the main, or after you put the stent in the main?
That's exactly the discussion we had last week at the EBC meeting. I prefer first use the DCB in the side branch and then forget the side branch, and then stent the main branch if you have to stent it. But there's a lot of discussion about this topic we have, so there are different views.
But isn't it that there's a danger of losing some of the drug while passaging through the stent struts of the main branch stent?
Yeah, that's exactly my argument against doing it. But the other argument was, okay, you can prepare, if you rewire, you can then predilate, and then you have a bigger ostium, and then you can go in with the DCB. So this was the argument against me, and I think both are valuable and worth to discuss.
Okay, I think we have time to address one more question. Yuri Melen asked, in de novo coronal lesions, do we always need to create a dissection, type A to C, using the code or not? Michael?
No, I don't think it's a necessary must to have a dissection. That is for sure. I mean, if I could, have a choice, I would go without a dissection. I think the dissection just shows you that you have achieved a reasonable vessel injury in such that you dilated the artery. And as I mentioned, I think a dissection per se is not something good to have because it requires healing. But as we know, and this is why I asked Bruno before, is the improved antiplatelet treatment these days. And I also believe that drug, partly paclitaxel and also sirolimus, they help in this healing process. And I think this is why we have better outcomes with drug-coated balloons.
Okay. Ar Abubanka, last question. This goes to you, Bruno. After this, any preference on ticagrelor or clopidogrel?
No, we do not have any data telling us the answer on this question.
Okay, so we are 30 seconds apart from the end. I first of all thank you very much for being with me today, provide all insightful thoughts. Second, I want to thank our colleagues because it's impressive the interest that this talk has raised because there are many questions. I apologize for those who I did not address. We will be back in a month for a second part of our webinar. And I think we don't need to underline nothing else that consider this technology as a safe and effective alternative in our armamentarium, especially when we deal absolutely with in-stent restenosis. This is my absolute first choice, unless you can see a very, very underexpanded or broken stent. And then for de novo lesions, we have to convince our colleagues about the efficacy and safety above all, because this is the main limitation of this technology when you see dissections and you don't know how to deal. Practice, practice, and practice, and the answer will come back. Thank you very much, Michael. Thank you very much, Bruno. Especially thank you very much to Europa, PCR, and Medtronic for this space. And special thanks to all our colleagues that joined us today, and hope to see you in less than a month for the second part of this DCB webinars. Have a good evening.